great majority of preclinical scientists like me work in a lab. They work usually in animal models, and they study the anatomy and the physiology and the very complex technology to understand how messages are transmitted. But I was interested in the patient, but I really didn't know much about the patient. And an opportunity arose, but it didn't take long before I got more engaged in the interview with the patient. But what I learned is how pain was impacting their life. Now, the fact is there are all kinds of conditions that generate clinical pain. And of course, we try to model some of these in an animal model. But the difference is, and what I want my students and postdocs to know, is that a mouse or a rat is not a human. And there's no question that animals experience injury stimuli and they will work to avoid them. But the impact of that stimulus on their life, on their quality, I have no idea what the impact is on the quality of life of a rodent. But I certainly could learn about the impact on the quality of life of the patient. And I could also learn about, well, the disappointing thing is how minimal the approaches are to treating. And that was the real eye-opener. I mean, I understand the complexity of pain circuitry probably as well, if better than most people in the field, because I've done it for so long. But you realize that there are elements of the pain experience that the patient has that you just don't know until you talk to them. So it changed the way I think about mechanisms, had I not seen that so powerfully. That's just one example of learning something by actually seeing it work, or in fact not work, in a patient, and learning that some things work in some patients and they don't work in others. These are things you just can't learn by just studying circuits in a mouse. And I want students and postdocs in my lab to be able to put their fundamental bench science in the context of the real clinical picture. We use the word translation all the time now. We want to translate from the basic science to, well, if you understand more about the patient, you can translate better. What I wanted them to talk and learn about what the impact of being a pain patient on their life, on their relationship with their family, on the fact that they bring a list of 20 different drugs that they've tried, which ones work, which ones didn't, the whatever, failed back syndrome that they've had multiple surgeries. There are ways to try to model, but are we really mimicking perfectly the clinical condition? No. And I recognize that. I can't do that for a variety of reasons. Number one, the brain of the human is different. They've had life experiences that are completely different. They're living with a partner who is supportive or not supportive. And there's a variety of reasons why it's different. But that's not why I'm trying to develop this model. I'm hoping that my model allows me, what I do, to be predictive of something that might work in the human. Not that it's trying to completely mimic the model. But this is a real issue. But I think if the individual learns more about what the clinical condition really is, then they might have a better appreciation of what they're trying to do in the lab, and some of the limitations. My guess is that the great majority of preclinical basic scientists have little to no experience. They might have heard a lecture. I'm sure they, that's the beauty of going to a plenary at an IAST meeting, and they'll hear a plenary talking about clinical picture. That's still not the same thing as to actually being there, sitting down and listening to the patient talk. It's an experience that is absolutely essential to appreciating the significance of what you're doing. One important corollary of seeing these patients is that I'm able to have discussions with clinicians. And that makes a big difference, is that most basic scientists can't have a conversation with a clinician because they've never seen a patient. And so I encourage the students and postdocs in my lab to go to the pain clinic and do what I did. Sit there initially and listen. The patients will be seen. They'll have sometimes medications. Other times they might have a procedure. They might have a spinal stimulator put in. These are anesthesiologists who do this regularly. You read about that, but you suddenly see the procedure and you see what it does to the patient. Wow, that changes the way the meaning, the power of your science.